Okay, for today, we are going to highlight a clinical study that we did at Henry Ford Health System a few years back. That's probably one of my favorite studies that we've ever done. This study looks at patient-reported outcome measures and how we can actually predict who's going to get better from surgery and who won't. In this case, we looked at patients undergoing surgery for a torn meniscus. And what we looked to find out was, can we predict the score change needed to signify a meaningful improvement? And then what would actually be a predictive factor in identifying which patient would get better or not? And this is all based on PROMs. In our case, as what we've done at Henry Ford and what we do at Protera, is that we use the National Institutes of Health patient-reported outcomes measures information system scores, which is basically boiled down to NIH PROMIS. These are the best scores that are available. And we look at a few scores from the vantage point of pain, function, mental health. Now, the other thing is that when we look at pain, we're not measuring a pain score from a 1 to a 10. Those, and we've studied this, others have studied this, those scores are fairly useless. You can have a pain score, an 8 today because you stubbed your toe, but really your knee arthritis is doing better. And so we look at something called pain interference. That is the impact of pain on a patient's quality of life. So we'll get through all that in this review, but I'm going to go through our paper and really drill down some of the take homes for you value-based healthcare leaders out there that want to learn more about PROMs and how PROMs can predict the future. So again, the topic was on this is predicting outcomes after a knee surgery, in this case, meniscus, but really these themes are consistent with spine, joint replacement, shoulder, you name it. A couple of things that we're going to highlight. We'll get through here, the introduction. And actually, I'll come back up here. As I mentioned, what we wanted to do was highlight first and foremost what we call the minimal clinically important difference. That is the minimal amount of score change that you need on a measure to indicate a clinically meaningful difference. So was it 3 points, 4 points, 5 points, 10 points? What does that mean? Because if you have a score change, it doesn't mean anything unless you know if it was clinically important or not. And I think that to me, actually, I think the secondary purpose is even more important. The secondary purpose, as I mentioned, was to identify which preoperative patient factors are associated with hitting that meaningful improvement. So can we predict in the office before surgery, will this patient have a good outcome or not? Now, there are some limitations to using these scores as predictors, but they do help us give a little bit of a data point. This study, we looked at over 160 patients that had meniscus surgery. We looked at them before and after, and we'll get into a little bit on what the data showed. From a methods perspective, I think that really going to drill down on one thing, and that's what we actually measured. We measured the PROMIS scores, which were the NIH format, and we looked at physical function, pain interference, and depression. And we looked at which one could be predicted for measuring improvement or not. We looked at a lot of other stuff, a lot of other demographic factors, smoking status, race, ethnicity, medical issues, and so forth. But the key is what scores were we actually looking at? And again, we looked at function, pain, and mental health. Now, for those of you who have followed along and know what we're doing at Protera Health, we are using these same high fidelity, high quality tools to take care of our patients in a virtual landscape and actually individualizing treatment based on these tools. So a lot of what we've done is learn from the science. So let's go down here. We'll get down, and a couple interesting things to point out. We actually found that smoking status had an impact, and the never smokers had significantly greater improvements than the former smokers or current smokers. I don't have a great explanation for that. In this case, this wasn't a big reconstruction surgery that required a lot of tissue healing and blood flow, but it was interesting to know that smoking had an impact at this stage. Now, when we look at the results, the first thing I mentioned was that we wanted to figure out what score improvement was meaningful. And if you look here at our results, at least in this scenario after surgery, what we found was that for physical function, the MCID was about 3.5 points. For pain interference, the MCID was 3.3 points. And for depression, it was 4.3 points. That means, for example, for physical function, if somebody achieved 3.5 points of improvement, that means that they were meaningfully improved. So that's how you could tell. So if you got an improvement of 2 points, it was okay, but not meaningful, not clinical, almost a statistical issue. And so that's really important. So as you're doing a surgery, you need to know what is a meaningful improvement and what isn't. And then down the road, we're going to talk about the CMS measures on patient-reported outcome measure collection and their requirements and what their thresholds are for hip and knee replacement. And this is going to come in handy for that. So anyway, so we identified what the score range on these tools were to denote a significant change. Now, the thing that really I think was telling to us was that if you started with a function score, PROMIS PF, a function score of under 35, you had an 83% chance of achieving this MCID, of meaningfully improving. Now, what does that mean? If you look at the PROMIS scores, the average score is about a 50. So if you have less than 50, it means you have less of that measure. So if you have a PROMIS physical function of 35, you have less function than the average person does, which is a 50. In fact, about 10 points is about one standard deviation. So you're a full deviation and a half lower function than the average person. And so what this is saying was, if you're starting at a low functional level or worse, you had an 83% chance of improving after surgery to a meaningful degree. What that also means is that the higher your function score is, the lower chance you have of improving. Now, you may say to yourself, that doesn't make sense. If you're coming in with a better function, you should actually do better from surgery. And the exact opposite is true. I'll give you an example. Let's say you have someone come in and they're a marathon runner. They've got great function, but they have a meniscus tear and they want surgery because they want to run 10% faster on their marathon time. Well, that's a very hard objective because you've got to hit a grand slam on that surgery to get that person better. They've got to recover well. Everything's got to go perfectly. And even then it may not get that improvement. Take somebody else who's got a meniscus tear and they cannot walk. It's a bad tear and they are miserable. They literally cannot move around. Any minimal improvement in that tear will result in a really meaningful clinical improvement because then they can start walking better, maybe do some exercise and so forth. So that's why the worse you start, the higher the chance is that you're going to have an improvement. Now, does that hold for pain? Now let's look at pain interference. If you had a pain interference score of greater than 67.6, 92% achieved MCID. Now you have to think about the pain scale rating. Pain interference, more pain interference means more impact of pain on quality of life. That is a bad thing, right? So in this PROMIS measure, higher scores are bad, which is the opposite of function where higher scores are good. But for PROMIS pain interference, higher scores are bad. That means pain is adversely affecting your quality of life. So what they're saying is if you are starting at a point above 67.6, which is again over 1.5 standard deviations above normal of pain interference, you have a 92% chance of achieving MCID. And so when you put these two together, if I'm talking to a patient in the office and they're coming in with normal scores for pain, normal scores for function, they may get better after surgery, but statistically speaking, they do not have a high likelihood of getting better after a meniscus tear in this context. That's where it really comes together. I'm going to show you some, let's see, where are those graphs here? Here we go. So when we look at the preoperative pain interference, remember I said in pain interference, lower scores are better. That means it's not impacting your life. So this dotted line is where the normal range is, that 50 to 55 range. So if you're on the left side of this dotted line, that means you're in a normal pain range. Guess what? Look at all these dots. These are the patients, right? After surgery, there's more dots that are having positive increases in pain interference than decreases. That means that you don't want to be in this blue. That means the change in your pain score is positive. It means you, after surgery, you ended up with worse pain. Now look at this side here, right? If you start off with significantly high preoperative pain interference, look at all the dots that are in this bottom part here with a negative change in their pain score, right? That means that they are doing much better and having less pain. And what we find when we look at the same thing with function is a similar trend. It's a little different because you have to think about the scales now, but let's look at the people that start off with really great function, okay? Again, 45 to 50 is about the normal range. So here's your 45 range. And you can see to the right of that are people with good function scores, at least according to the NIH PROMIS measures. And what we see is the higher your function score is, look again postoperatively where your change in physical function is. It is negative. So again, what we're seeing is the better you are before surgery, the worse you will do after surgery. When you look at the other side of things, the folks with really low functions, 20s, 30s, which is very, very low, that 35-point cutoff like we talked about. After surgery, look at all the number of dots that have a positive increase in their physical function compared to the decrease in function, right? So you're higher chance of doing better after surgery if you start off in a worse physical function state. So to summarize, this is a study we did at Henry Ford a few years ago, looking at our patients that we operated on that had degenerative meniscus tears. What we sought out to do was figure out, can we determine the point change on the NIH PROMIS measures for pain and function that signify a meaningful clinical improvement? And then secondly, can we predict who's going to get better or not based on their preoperative scores? And what we found was not only could we detect that threshold change, we actually found that the worse you were from a pain and function perspective before surgery, the higher the chance you were to get better after surgery. This was super surprising to me. I actually, going into the study, thought it would be opposite, but I had seen some research indicating that might not be the case. And so I wasn't, overly surprised with the findings, but it certainly changed my opinion on how I look at PROMs and with patient care. And this is probably one of the biggest changes made in our practice is having these scores at my fingertips. I can counsel patients better. And again, as mentioned before, we use these scores throughout the care journey of Protera Health to make sure our patients understand what their pain and function is. Because if they're in a normal range, we can safely tell them, hey, outside of any red flag signs or any sort of concerning, findings, you'll probably do well with non-operative treatment. And that's really powerful for patients to hear. I hope you enjoyed this. Stay tuned next week for some more insights from our newsletter. Please feel free to reach out if you'd like to discuss more. And I hope you all have a great day.